Hello everyone. This is our presentation on nursing terminologies, and presenting to you will be myself, Bethany Voigt, Catherine Kavanaugh, and Joanne Mejia.
Most people believe that nursing began with the work of Florence Nightingale, pictured here. She successfully established nurse education programs in numerous British hospitals upon her return to England in the 1850s. Her work confirmed that educated women who were well informed about health and the ways to promote it could improve the care of patients based on a set of particular principles. The era of evidence-based healthcare is requiring that nurses begin demonstrating that the care they provide is associated with optimal patient outcomes with high degrees of quality and safety. With the use of classification systems and standardized nursing terminologies, there is now a way that nursing documentation can be leveraged to generate the evidence needed for the nursing practice. There are several widely reported nursing-specific classifications and terminologies used today.
The objectives are to develop a better understanding of the following terminologies by reviewing their history and governance, purpose and function, and structure and content for the following nursing terminologies we chose: NANDA International, Omaha System, Clinical Care Classification, International Classification for Nursing Practice. Hi, my name is Joanne Mejia, and I'll be presenting the nursing terminology NANDA International. History and governance. North American Nursing Diagnosis Association was officially founded in 1982, and it develops, researches, disseminates, and refines the nomenclature, criteria, and taxonomy of nursing diagnoses in the US and Canada. In 2002, the association relaunched, changing their name to NANDA International due to their membership growing outside of North America. Along with changing their name, NANDA published nursing diagnoses, and this was done quarterly, which became known as the International Journal of Nursing Knowledge. The NANDA International Board of Directors establishes administrative policies governing the affairs of the association. The board develops and implements a plan toward the accomplishment of NANDA's purposes. Then a report is provided to the membership at a regular meeting. Purpose and function. Implementation of nursing diagnosis enhances every aspect of the nursing practice. For instance, it represents the nurse's clinical judgment, also provides accurate documentation to enable reimbursement. Nursing diagnosis. It is used to determine the plan of care for the patient, interventions and outcomes that would help carry out the plan. Also provides standard nomenclature for use in the electronic health record, allowing for clear communication with all healthcare staff. The American Nurses Association recognizes NANDA as one of the standard languages of nursing. Moreover, NANDA meets the Joint Commission Standard Uniform Data Set. It is also registered in the Health Level 7 and is mapped in SNOMED CT. Structure and components. The system assists nurses to describe the patient's responses to diseases rather than classifying the condition. The NANDA classification has 13 domains, and within each domain there are 2 or more classes. For instance, in the domain self-perception, there are 3 classes within this domain, which are self-concept, self-esteem, and body image. The coding structure is for nursing diagnosis only, consisting of 5 digits.
Thank you, Joanne. Now I, Bethany Voigt, will be going over the Omaha system. The Omaha system was developed by practitioners of the Omaha Visiting Nurses Association, or VNA, in the 1970s. This organization insisted that this system be research-based and a comprehensive classification that would provide useful practice guides for practitioners, administrators, nurses, and other potential users. In addition, documentation and management of information enhancement is designed into the structure for healthcare needs. So essentially, the VNA utilized these efforts to build a system of standardized terminology for nursing processes specifically. Now, a bit of history on the Omaha system. During the years 1975 through 1986, the system began refinement by the Division of Nursing under various grants to expand the disciplines and usefulness with the remodeling of healthcare data and care. Following those years from 1989 to 1993, the focus of the refinement was on the aspects of reliability, validity, and usability research. Now these references focus on client needs and data usability. In addition, during the year 2001, a 12-member advisory board was created to review and revise the system based on results from comments of users from survey results on conducted system research studies. The Omaha system is also currently recognized by the American Nurses Association, or ANA, and was first recognized by them in 1990. It is also included in other applications such as SNOMED CT and the accreditation standards of the Joint Commission. With this, the terminology is also used internationally, in which it can be translated into various languages for usage. Moving on to the purpose and function of the Omaha system. The purpose of the Omaha system is to provide an essential terminology standardization that can be used across a care continuum in offering approaches to document patient problems, support the provided care, and have an outcome measurement. Specifically, individuals like to refer to this application as comprehensive and as a documentation tool. This type of system is mainly used in home care, hospice, long-term care, assisted living, even schools, and hospital-based, as well as public healthcare settings. With this, the components of the Omaha system will be introduced in the next slide. However, they offer functions of documenting needs and strengths, relating clinical interventions, and again, measuring those client outcomes. When the components are utilized synchronously, the clinical data of patients is then linked to other types of data involving demographic, financial, administrative, and staffing. So information can be focused on at greater lengths while the system remains flexible for users. The Omaha system has three main components, which are assessment or problem classification scheme, intervention, and outcomes or problem rating scale. The assessment component organizes the patient problems, whether they be environmental, psychological, or health related, and can involve things such as income or communication abilities, development or growth, and even disease-related occurrences. For the intervention component, this involves analyzing the type of care being given to patients based on the associated problem they are presented with. And finally, the component of outcomes addresses the ratings of client progress and outcome from admission to discharge. Now we will each be covering a section of the clinical care classification terminology, and I will begin with history and governance. The Clinical Care Classification System, or CCC, was previously referred to as the Home Health Care Classification, or HHCC system. With this, a woman named Virginia K. Saba conducted a project that presented the CCC system from the home health system in 1991, and this took place at the Georgetown University School of Nursing. Furthermore, this system composed of a CCC of nursing diagnoses and interventions was recognized by the ANA in 1991 as well, just a year after the Omaha system. The ANA, or American Nursing Association, also ensured the terminology would be practiced, supported, and promoted with electronic health record usage. Additionally, there is currently no specific update or revision schedule in place, which for us is important to be aware of with the requirements of nursing documentation today as well as in the future.
Purpose and function. Clinical Care Classification System, also known as CCC, provides standardized framework and unique coding of nursing plans electronically. It facilitates the collection, storage, processing, retrieval, and analysis of clinical nursing practice. It is used for clinical nursing practice applications to capture patient data. It links clinical concepts such as problems, goals, interventions, actions, and outcomes together. CCC provides concept for clinical pathways and decision support systems in the electronic health record. It is used in nursing administration applications to capture patient data to measure effectiveness of patient outcomes, quality, and safety. At the same time, it uses RVUs to predict workload, resource needs, cost, and nursing care.
The framework for the CCC, as you see listed, is components, nursing diagnosis, nursing interventions, and nursing outcomes. The components of nursing care is defined as a cluster of elements. They are represented by a unique pattern of clinical care nursing practice. The elements used are health behavioral, functional, physiological, and psychological. Each represent different sets of care components. The nursing diagnosis provides the groundwork needed for determining a plan of action to achieve the expected outcomes. The nursing interventions are the nursing actions. This can be a treatment, procedure, or an activity to achieve the outcome of the diagnosis. Nursing outcomes can be labeled as improved, stabilized, or deteriorated. These are expected outcomes and actual outcomes listed within the nursing outcome concepts. The expected outcomes represented the goal of the patient in the future, where actual outcomes reflect where the goals were not met. My name is Catherine Cavanaugh, and I will be discussing International Classification for Nursing Practice, ICNP. History and Governance. ICNP is a classification of nursing phenomena, nursing actions, and nursing outcomes that describe nursing practice. It has been a project of the International Council of Nurses, ICN, since its development in 1989. In 2000, the formal ICNP Programme was established. The vision of this program is to have nursing data readily available and used in healthcare information systems worldwide. In 2005, version 1.0 of the ICNP was released, and in 2013, ICNP released another version to include a new web browser and added content. The purpose and function of ICNP is to extend coverage of the domain of nursing practice as a complementary and essential part of professional health services. ICNP classifies patient data and clinical activity for uses of decision-making and policy development, which aim at improving healthcare delivery and health status. It also can improve communication and statistical reporting practices across health services. Lastly, it can also be used with other WHO FIC classifications wherever such care is provided. INCP structured their formal foundation in a polyhierarchy that is used to compose and represent diagnosis, intervention, and outcomes of patient care. There are a number of subsets that are available to provide pre-coordinated concepts for the various health priorities. A few include nursing outcome indicators, pediatric pain management, palliative care, and then a partnering with the patients and their families to ensure the patient is adhering to treatment. Please see our reference page on articles we use to help capture the detail within the presentation. Thank you for your time, and we hope you are able to take away valuable information from this presentation. Does anyone have any questions?